some people will actually poke the aneurysm after it's clipped just to make sure it works. And fun fact, back in the day, Jeremy was actually telling me that some older surgeons, when they didn't have like all these fancy clips and stuff like that, they would use super glue, and it worked. So Dr. White, he's actually one of the neurosurgeons, one of the attendings at UT Southwestern. Jeremy would say that like a long time ago, he would tell his colleagues, I need you to stop by 7-Eleven, go get some super glue and meet me in the OR. And they would just use it, just like that. They would just put it around the aneurysm. That way, if it ruptured, it'd be stopped by this wall of super glue. Like, the more glue you put around it, the more stable it is. And, technically it would still work. They obviously don't do that anymore. Like, super glue has been compared to skin glue, which they use when they, suture people up. It's pretty much the same thing, only skin glue causes a little bit less irritation and it's dyed purple. But it's very interesting how things have, evolved. Next up, we have a transsphenoidal brain tumor removal. So transsphenoidal is a very large word, I know. Basically, it just means that you're going through the nose to do the whole thing. So this is a collaborative effort between neurosurgery and ENT. ENT stands for ear, nose, and throat doctors. They do a lot of surgery, actually. How they do it is first ENT will go in there, and they have these really skinny instruments, and it's just a lot going in and out through the nose. But ENT will go in there, and they actually take out the sphenoid bone. So you can see, if the tumor is right here, the sphenoid bone is kind of blocking the space in the sinus. So they have to go through and cut through here and remove that. And they take it out piece by piece, and then neurosurgery will come in and remove the tumor bit by bit. So it's a very, it's kind of a slow process, but it's very interesting to watch. And it's not as invasive as other brain surgeries because you're just going up through the nose, so you don't see any incisions being made or anything. And oftentimes after they remove the tumor, there's this, blank space just right past your nose. So they take a fat graft from another part of your body and they kind of put it up there to fill the space. Next up, we have an ACDF or a PCDF. So this stands for anterior cervical discectomy infusion or posterior cervical discectomy infusion. This is a spine surgery. I've seen a couple of these. This is when people, say for example they had cervical myelopathy, which is what I was talking about before. They might, maybe they have a pinched nerve or something, or they have cervical kyphosis, which is just when you're a hunchback and their spine needs to be stabilized. So what they do is they take one of the discs, the cartilage spaces in between your vertebra, and they take that out. They have these little drills that are kind of they kind of sand it down in a way. The drill spins really fast, and they just sort of sand it, and they take out the disc, and then from there it comes to fusion. So how they do the fusion is they put in screws and rods to sort of connect the vertebrae to make sure they stay in place. I'm going to be honest, I don't really like watching spine surgeries as much. They're so cool to watch, but you can't really see much unless you're just standing right above it. Once they get under the microscope, you can see a lot more. But it's not my favorite thing to watch, but I have seen a lot of them, so I decided to include it. And I wasn't sure how much time I would have, so I didn't include some of the other surgeries I've seen, but I've gotten the chance to see so many different surgeries, cranioplasties and subdural hematomas and aneurysms and so many brain tumors. It's been so incredible. So one thing I also wanted to talk about was Wednesdays. So on a typical day that I would go to Parkland, I would get there at 7:30 in the morning, and then they would do rounds for all their patients, and then we go down to the OR, and I would just observe surgery from there. But Wednesdays are a little different. Wednesdays are their designated clinic days. So on Wednesdays, they typically don't operate unless it's an absolute trauma. So they have their neurosurgery clinic at Parkland. It's still at the old hospital, even though we've already made the transition to the new hospital. But clinic is where they see all of their patients just for routine consults, post-op checkups, or say you fell and you got a CT and you had a subdural hematoma, you didn't know where to go from there, you would go to clinic to get, further instructions, that kind of thing. And on Wednesdays, they also do this thing called vascular conference. So since this is all under UT Southwestern, they do a lot of things to get the residents involved and promote learning in their environment. So they have 3 conferences they do every week. They have spine conference, tumor conference, and vascular conference. What they do at these conferences is it's every attending from the university, whatever residents can go, people from neurology, neurocritical care people, so many people come together. And usually one of the junior residents will first of all present some kind of presentation over some new thing, some new method to do something, or some new idea or something to like, for example, you know how we all present our presentations to teach people new things? This is what they're doing, only it's just specifically like neurological stuff. So I've learned like some really cool things, you know. They're promoting new things in their atmosphere every day, and then after that they go through all of their tricky patient cases, they pull up the scans, and everyone will like collectively think of a solution together. So it's really cool to be a part of this. This is not the actual clinic room, it's just the idea of it. But vascular conference starts at like 7 o'clock in the morning, so I don't always go, but I've been a few times and I definitely want to go more in the future. And I try to kind of go to clinic every once in a while because I don't want to just see surgery, I want to see everything. So now I'm just going to get into my original work really quick. So my original work is actually part of my final product. For my final product, I'm doing like a mock clinical trial. I'm looking at people that have subdural hematomas, which is what I was describing earlier, and I'm looking at how draining it maybe like a few days after they're diagnosed versus draining it maybe like 2 or 3 weeks later affects their motor strength in the long run. I'm looking at to see, I'm trying to find out if people that get it drained later have more problems like moving their arms and legs and stuff like that. So I did like background research first. My first source was this book, The Handbook of Neurosurgery. My mentor let me borrow it, and it's the hardest book I've ever read in my entire life. I read 5 pages from here, and it took me like several hours. It's so hard to read. You have to be like a med school graduate to understand it properly. And then I had other online sources. I don't think I have enough time to get into like everything, but I also did a paragraph on, like what a subdural hematoma is, how do you treat it, what causes it, and I also did something about the pathophysiology behind it, like how if you leave a subdural hematoma in a brain for a longer amount of time, the blood will actually thin out because the fibrin in your blood is broken down, and the fibrin is the thing that promotes a blood clotting. So I did a lot of stuff, like research about that, and I also wrote like the intro for my write-up, which will then be used. I think I'm going to put all this in my write-up for my final product, but I kind of wanted to get started on it now because it will be a really long process. So just really quick, I have a very graphic video of a subdural hematoma surgery. So this is an acute subdural hematoma. That means that it's very like fresh in the brain. It's only a couple days old. It's trauma. This is what the scan looks like. That's the blood. So they've already cut into the scalp and stuff, and they've already cut into the skull. So the blood, it is a blood clot, so it kind of have like, it forms like a membrane around itself, so it's like, it's not solid exactly, but it is like its own body, I guess. So they're cutting through the dura right here. And there's the blood. So since it's so fresh, they can just kind of scrape it off because it's not binded to the brain or anything. And you can see there's still bleeding right here, so they're going to coagulate it to stop the bleeding. See, they're coagulating it with the bipolar leads right here. It's okay. So that's just one example. So I'm going to leave you guys with a quote by Casey Neistat: "With each success must come a newer and more ambitious goal." This has like kind of encouraged me to sort of move forward and pursue bigger goals. So thank you everyone for listening. I think I'm done. Sorry.